Justice. Oops. You probably all just got the recording notice. So again, my name is Rachel Justice, and I am one of the program managers with the Woman to Woman program at Mount Sinai Hospital in New York City. I run the program with my colleague, Jillian Levinson. And we are just one of many Woman to Woman programs. We did start at Mount Sinai, but we now have almost 40 programs expanded through the Ovarian Cancer Research Alliance throughout the entire country. And as you might be aware, that this is a multi-organizational collaboration between a whole bunch of different organizations. So we have WOCA, the Wisconsin Ovarian Cancer Alliance. We have Discovery to Cure. I always get that wrong. Am I right, Ruth Ann? At Yale New Haven. We have Shersheret, which has a presence in multiple places. We have Judy's Mission, which is based in Texas. We do have Teal, Tell Every Amazing Lady. Am I forgetting anything? I don't think so. Those are all of our organizations, and we're thrilled to come together because our missions are really, really aligned. And that is to make sure that any woman that's diagnosed with gynecologic cancer, any type of gynecologic cancer, ovarian, cervical, uterine, endometrial, understands that you are part of a community now. This is a community that wants to share information and resources and support however we possibly can. And you have come to the right place. So whether you are here live or you're watching it, we're so glad you found your way to this video. We are going to have a multidisciplinary panel. Our first speaker, and the way we usually do this is we have a gynecologic oncologist. I'll be telling you details, followed by a psychosocial expert, and then you'll be hearing a survivor story. In terms of questions, if you could just hold your questions, please, until the end, or you can put them in the chat, that would be great. We will make sure to answer as many questions as we possibly can. If we don't get to all of them, we will give you contact information so you can send an email via Ashley at WOCA to make sure your questions get answered by the appropriate speaker. And I think without further ado, we are going to jump right in. So I'm going to introduce each of our speakers before they go. Again, our goal is to finish in about an hour. So Gary Altwerger, MD, is a gynecologic oncologist in the Department of Department of Obstetrics, Gynecology, and Reproductive Sciences at Yale University School of Medicine. Dr. Altwerger has a special interest in early uterine cancer detection, identification of predictive and prognostic biomarkers in precancerous lesions, and has been published in Novel Treatment Techniques for Gynecologic Cancers. He is currently the supervising physician for the Inpatient Gynecologic Oncology Physician's Assistants and Assistant Director of Inpatient Gynecologic Oncology Services, and serves on the IRB committee reviewing cancer research protocols at Yale New Haven Hospital. Dr. Altwerger's laboratory is working on identifying ways to target DNA repair pathways in advanced uterine cancer. He additionally is implementing novel surgical techniques for the treatment of early stage gynecologic cancer. Dr. Altwerger is the PI on multiple rare gynecologic cancer protocols. So we are really, really thrilled to have you with us, and we will turn the virtual microphone over to you.
Great, thank you so much, Rachel. It's great to be here and to be able to talk with all of you about these diseases that we see so often. And let me know if can you all see my screen? Let's see. Let me see if I can turn it into a slideshow here. Okay, can everyone see my screen? I can't tell.
Yes.
Good. Oh, yeah. Excellent. Thank you. Sorry, I'm not. Yeah.
Yes.
Wonderful. So good. Yes. So I I appreciate that you guys have the ability to have everybody come here and listen to this this great interdisciplinary team and so we could really talk about the kind of the basics of gynecologic cancers and kind of I just kind of want to give everyone an introduction to gynecologic malignancies and the process that I've seen from my standpoint over the years in terms of how patients are from the start diagnosed, how patients are treated, where patients go after they're treated, and the team members that are involved in really the whole process of their care. And I think that roadmap will help give everyone a little bit more comfort in their treatments and in their journey with their gynecologic cancers. So as Rachel had stated, I am an assistant professor at Yale University, and I've been here as an attending for many years, and I'd like to continue that because I have many research ideas and projects that I'd like to continue. And so we can start with the introduction of gynecologic cancer. So gynecologic cancer is a rare disease, and it does on a yearly basis afflict about 100,000 women in the U.S. per year. And it is, fortunately, it is less common than breast or colon cancer or a number of other types of cancers. But it is a dangerous cancer, and it does bring on a lot of issues for a lot of people in terms of families can be really hurt from this when the matriarch of the family contracts ovarian cancer, uterine cancer, or cervical cancer, and it really does change family dynamics, whether or not it's talked about or not within that family. And because it's a gynecologic malignancy, it isn't talked about as much as breast or colon cancer. And it's something that we need to change. And in fact, we even need to change it with insurance companies. It's my plug to really push insurance companies to do a better job of helping out women with gynecologic cancers. I think that's not spoken about enough. There are millions of survivors of gynecologic cancers in the US, and that's really a testament to groups like this who have really pushed the boundary for early diagnoses, screening, really pushing for clinical trials. And this has been a game changer and really has led to a lot of these advances. And almost on a monthly basis, I have to tell you, there are new treatments that come out and approved by the FDA and approved by insurance. And so we've really seen a lot of headway, even in the last, I have to say, 5 years. And it's very, very impressive. And I think a lot of that has to do with groups like this, again, really bringing to the forefront the issue in gynecologic cancer. And so, I was going through the CDC website, and actually this came up, and I think that this is a timely series, I guess. And so it's really talking about having women kind of speak to their gynecologist about the symptoms that they're having, and in this case, it's not just about cancer, but about any of the symptoms. And I think that's really important, because I think a lot of times the symptoms that you can get from ovarian cancer, uterine cancer, cervical cancer, they can be very non-specific. And so the most important thing is to talk about it. And the best place to talk about it is at the gynecologist. The next best place is at any of your physician's offices. But I think this series, I haven't seen it, but I think probably it's helping to get people to talk to the gynecologist instead of kind of keeping quiet about symptoms that they may be having. So the gynecologic cancers that are really the most common are uterine cancer, ovarian, and less common cervical, vulvar cancer, and probably the least common is vaginal cancer. Those are really the most typical cancers that we see, the top 5. We also see trophoblastic cancer. That is a little bit more rare and not really something that I will touch on in this presentation, but it does exist, and I want to at least make sure that we have the name out there so that we can recognize it in the future. And so the next slide is really kind of the nuts and bolts of a single cell in our body. And that is, let me see if I can get a pointer here. I think I can. And that's really highlighted here. That's a single cell, and in this type of cell, these are like any cells in our body. They have DNA that's shown here, that can gain mistakes in their base pairs here. And this is really the blueprint for how the cell is going to work. And any pathway along here, there can be any mistakes. And mistakes in that pathway can take a normal cell, seen here, and turn it into a cancer cell. And the reason why that's important, not to scare anybody that there's many places where there can be mistakes, but rather so that everybody understands that there's many places where we can work to fix these cells, and also work to identify cancer early. If there's an early mistake in one of these areas here, that's something we can use in the future to try to predict or identify people before they go from a normal cell that just has a mistake in their DNA to an actual cancer cell. So I think that I wanted to give you the background here about why it's important to talk about the DNA and the genetic makeup of the cell, because there's a lot of therapy now that's based on that. And so here we just have the normal cells going through phases of dysplasia, which means cell abnormality. And that's important. I wanted to bring that word up because it's a word that maybe people have heard here. And it's a precancer. And there's different grades of dysplasia, but it's a precancer. So in general, people will come to my office and they'll have been diagnosed with dysplasia, and it'll sound like that it seems to them to be cancer, but it may actually be precancer. But it can progress to cancer, and that's why we want to make sure that people understand that what dysplasia is versus cancer. Now, cancer is a dysplasia with invasion, and so that invasion you can see here coming through. So that's just some nomenclature there, and here I just wanted to talk about the cancers: the uterine cancer, ovarian cancer, cervical cancer, vulvar and vaginal cancer. Those cancers, when we talk about when they're first diagnosed, we have to understand what stage they are. They could be early stage, which is generally stage 1 and stage 2. They could be a more advanced stage, stage 3 and 4. Now, stage 1 generally can be fixed or cured with surgery, and generally people have a good outcome from that. And we measure that outcome by 5-year survivals. And the 5-year survival is important to understand really what our chances are for doing how we do with our types of cancer. And so stage 1, generally people have a good 5-year survival. And of course, as we go down the line here, when we get to stage 4, the survival at 5 years, the percentage of people surviving at 5 years with stage 4 cancer is a bit lower, something around 40 to 50%, as opposed to in stage 1, the percentage of people surviving 5 years is about 90%. Then we also have something called grade, and that's how the cell itself, how it looks, not where it's gone, but how it looks. Is it a little bit more aggressive, which is grade 3, or is it a little bit more slow growing, like grade 1? And so those are two very important aspects to all of the cancers that we talk about. And so it's important to ask your physician about what's your stage and what's your grade, because that's the first thing that we need to know to be able to understand how to treat it, and how overall you'll do. And again, the stage for uterine cancer and ovarian cancer and cervical cancer is generally we talk about a spread to, this is something called the abdominal cavity here. It's generally a spread within the abdominal cavity. So we have up here, we can barely see it. It's the edge of the liver. And here we have the edge of the stomach. This is the fat pad around the stomach, which maybe some people have heard about for ovarian cancer, maybe uterine cancer. Then we have the intestines here. The small intestines are in here. Uterus is here. And so what we understand is that sometimes with uterine cancer, this can spread to the abdominal cavity, same as ovarian cancer, that can spread to the abdominal cavity. And cervical cancer can as well. It's a little bit more rare to see that. And here we just have the lymph nodes that are kind of highlighted in green, just to show you where the lymph nodes sometimes are that get also can get cancer within them. And so the symptoms really, when we first are diagnosing gynecologic cancers, are very vague. And I don't say this to scare anybody, because I know we all are when we've been diagnosed with cancer, we're all really thinking about what are the symptoms that we could be having. But it's important to still keep these in mind. But if they're not consistent symptoms, then it's less likely that we have to worry about them. If they come on for a couple of days and go away, then that's something that maybe it's not something we have to really worry too much about. Still talk to your physicians about it. But if they keep coming back and they stay persistently, then that's a problem. Now, bleeding, that's the caveat. Bleeding, no matter what, any vaginal bleeding, if you're postmenopausal, that's a big deal. That has to be evaluated. Or any abnormal bleeding in somebody who doesn't have a regular period, that's also abnormal. Same with discharge, vaginal discharge. These bloating, nausea, that's a little bit more vague, but still pay attention. Again, if it's persistent, you have to let a physician know. Early filling, you go to eat and you can't eat as much as you used to be able to, particularly if you're having weight loss, you're having early filling and also bloating. Those constellation of symptoms altogether can be concerning and need to be evaluated. And changes in bowel habit. Now, the evaluation is pretty straightforward. Usually it's just a quick CT scan. I know it's less than ideal to have to go for one, but it's a pretty straightforward scan, and same with ultrasound. And so if you talk about these symptoms, it's not a long, laborious process. It's really just a CT scan or an ultrasound to figure out what might be happening. So it's better to talk early about these things and go for these CAT scans. Even if you've already been treated for cancer and it's been years and years and years, still bring these symptoms up, and it's easy enough to get a CAT scan. So for the initial diagnosis, we usually biopsy the uterus, cervix. If it's vaginal cancer, we'll biopsy the vagina. If it's vulvar, the vulva. The vulvar cancer is on the outside of the vagina. The vaginal cancer is obviously on the inside of the vagina. And if there's a mass or in the abdomen, we can biopsy that if it seems that there's no pelvic masses. And in general, sometimes when there's an ovarian mass, we can't biopsy that because we don't want to disrupt the ovarian mass. We want to keep it intact. And if it's just an ovarian mass, we might just say we can resect it and get the diagnosis. And that's generally what we do to diagnose an ovarian mass, or if there's any vaginal bleeding, the uterine biopsy or cervical biopsy, and so forth. The treatment after we have a diagnosis, after these biopsies, is generally surgery. We can do minimally invasive surgery. We can do open surgery. And that really depends on that type of cancer. So for each type of cancer, it's a little bit different. And we have many studies to tell us which modality is better. We then can do chemotherapy if we need to up front, if it seems that it's advanced disease. If it seems that it's early stage disease, we usually do the chemotherapy afterwards. Some types of cancers, if they're early, we don't have to treat with chemotherapy. Radiation is a similar kind of mainstay where we don't always have to use it, but if we're going to use it, it'll probably be in cervical cancer or uterine cancer. We don't usually use it in ovarian. Sometimes we use it in vulvar cancer or vaginal cancer. Things that are important, you need to ask questions about these things to your physicians, and you shouldn't feel bad about asking questions in the visits. And it's our job to educate people, and really we're teachers more than anything else. And I think that it's important to remember that, and to really advocate for yourself too, and bring a person along so they can also listen to what the physician has to say. And if you want to record what the physician's saying, if you ask the physician, I'm sure they would be okay with having it recorded so that you can go back and refer to it. Now, some questions that I think are important, really when you're first diagnosed. First, first and foremost, what's the stage and what's the grade? Now, they might not be able to answer the stage yet because it may be that, like with uterine cancer, you can't get staged until you have the surgery. And so that's okay if they say they don't know, as long as you all have a plan to kind of figure it out. And so that's an important thing to get right off the bat, stage and grade. And then when do you start treatment? And sometimes there's a delay in treatment, and it's not really a delay, it's because you have to get surgery, or you have to have chemo, and then you have to have surgery, but you need some time between chemotherapy and having surgery. So maybe you won't know about much of the kind of the stage. And the other interesting thing is that if you get chemotherapy up front, you may not have a stage. It might be just advanced stage for right now, while you're getting chemotherapy before surgery. You want to know about the length of treatment. You want to know about the symptoms that you'll have when you're getting chemotherapy. You want to know if there's any maintenance therapy that you could get, or any targeted therapy that you could get. Sometimes that can't be upfront with chemotherapy, but you got to ask anyways. Make sure you ask about targeted therapy. And it's not being annoying, but it's important, because you got to, again, advocate for yourself. And there's so many changes that are happening so quickly. It's hard to say whether, within a couple months, it may be that there's more targeted therapies. So be sure to ask that, whether it's a recurrence or the first time. You need to make sure whether or not you need genetic testing. I would advocate for people just to ask your physician. I mean, you don't get genetic testing for cervical cancer or vulvar or vaginal cancer, but sometimes uterine cancer and always ovarian cancer. So I think you wouldn't go wrong if you asked. Ask if they test the genetics of the actual tumor. The genetics of the tumor might be different than your own genetics. They're two different things sometimes. So don't be scared to say, hey, what about the genetics for myself, but also for the tumor? And also be sure that, you don't always have to follow the exact regimen of the chemotherapy. It's good to stick pretty close, but if you want to take a 2-week vacation, and be sure to ask your physician if that's something that you might be able to squeeze in. That's, in my opinion, totally fine. And who to call if you're having side effects: fellows, nurses. What's the number? Who do you call late at night if you're having issues? And you should also know that you're not going through this process alone. There are many patients who've gone through this process. There are many physicians who know about this process that can help educate you. I mean, obviously, you guys have already taken the first step in coming to this meeting, and and you understand that this isn't a process alone. I think, what makes me sad though, although maybe it's a personal preference, sometimes I have patients that don't want to talk, want to come, or go to groups and see that other people are going through this. And that's your own personal preference. And that if that's a preference, then that's totally fine too. I think that though these groups really help people. And also you should know that there's a whole team. Social workers are very important in our practice here. They help us have discussions about end of life. They help us have discussions about what to do for patients that are having a lot of pain and issues with chemotherapy. They help us integrate in issues with insurance companies, and they can't be kind of applauded enough. And palliative care for pain control, get them involved early. It doesn't mean that you have to go to hospice if you get palliative care involved. Palliative care is very helpful with pain control. And radiation oncologists obviously are good for us for radiation aspects. We all work together with the medical oncologists as well as physical therapists. And then we also like to refer to genetic counselors, particularly for ovarian cancer, sometimes for uterine cancer. And so just to let you know that we have a really robust team around the patient. And so I just wanted to remind you that it's really important to speak up about these things and really advocate for yourself. And that's how I'd like to end it. I'm sorry if I went over. If you guys have any questions, I'm happy to answer.
Thank you so much. That was really, really so helpful, and such a great way to start throughout our presentation. I think just starting with the basics, because I think a lot of people are just blindsided when they get this diagnosis. And I think sharing the statistics and explaining the difference between stage and grade is so helpful. And I think your message that's most important to take away is ask questions. There are people on that team. I love that graphic with the kind of fold over. It looked like a bow you would find on a present, but so many members of the team who you can ask, depending on who you're most comfortable with. And if you're not comfortable speaking to the doctor, talk to the social worker, talk to the nurse, the physician's assistant, whoever it might be. And, just that everyone's there to answer and to help you get as much knowledge and get connected to resources. So thank you so much for that really, really helpful presentation. We are going to switch gears now, and we're going to focus not just on the medical, but on the psychosocial. So we'll be joined next by Amy Sachs, MSW, Share Shirt California Support Program Manager. She's a graduate of Washington University in St. Louis and the UCLA Luskin School of Public Affairs. Amy assists in the delivery of Share Shirt's cancer support programs and coordinates tailored support and resources for people living with and at high risk of developing breast or ovarian cancer. Amy, thank you so much for joining us from LA. We are thrilled to have you here and really excited for you to piggyback onto the presentation we just had about the medical end of things. So thank you so much.
Absolutely. If they can see anything.
Absolutely. No, that was really a perfect way to start. Thank you so much for having me. And thank you, Dr. Altwerger, for the shout out to social workers and what we can do. You helped get this started off right. So, oh, hold on, I'm having trouble. Okay, there we go. So I'm going to go quickly as possible because I know we're a little over time. So if you have questions, we're going to have a Q&A at the end. So definitely save them or put them in the chat. So Share It provides free, confidential, and personalized support to people, across the country, and even some people outside of the country. Our focus is on ovarian cancer and breast cancer. However, we help people with all gynecological cancers. And honestly, I spoke to somebody last week with laryngeal cancer. So if you know anybody looking for support with any type of cancer, or you are somebody with a different type of cancer, please feel free to reach out to us. We are a Jewish organization and proud of that, but we serve everybody regardless of background. So that shouldn't be a deterrent either. There are lots of different types of social workers. You might come in contact with a social worker at the hospital or at your doctor's practice. There's a lot of overlap between what those two, settings of social workers would do. They also might be at a, cancer center, an integrative medicine center, something like Cancer Support Communities or Gilda's Club. The ones within the hospital or your doctor's practice, can really help you with understanding how the hospital works, how the practice works, what to ask the doctor, how to get in touch with the doctor. They might be able to help with insurance and local resources, financial assistance, transportation, those types of things. Calling a Share It social worker can kind of fill in the blanks. One person once told me I was her cancer concierge. She could call me with any questions, and kind of try to think of social workers as just someone who can help. You don't need to reinvent the wheel. You don't need to become an expert. You will become an expert in the type of cancer that you get the diagnosis for. But we're here for that. We're here to be your first stop before Google, because we've probably already Googled it, or we probably already have a resource list for whatever type of resource you're looking for. So, here's some examples of things that you can ask your social worker. Certainly, we will tell you that's a question for your doctor, or that's a question for so-and-so on your treatment team. But sometimes asking for a question, or clarification about something that somebody on your treatment team said, sometimes people come to me with that. And I do know, what kind of side effects they might, be expecting, or the kind of way that side effects can ebb and flow. And I have tips about, kind of different questions they might have. So you can always bring those to us. discussions about decision making, right? There's so many decisions that you have to make once you have a cancer diagnosis. And, you know, so often you'll come to a social worker with, I'm trying to decide, my doctor's telling me it's my choice. I wish they would just tell me what to do, but they won't. And a social worker should never tell you what to do. It's our job to help you decide what's best for you. And, you know, whatever the issue is, whether it's, you know, my sister said this thing and I don't know how to deal with it, or I don't know what to tell my work, or I don't know what to tell my kids. You know, we're here for all of that. So certainly I'm not a marriage counselor, but I end up having those types of discussions every once in a while, and I'm happy to. And then, you know, resource referral, that's really what social workers often excel at. So, you know, resources like support groups, counseling, financial assistance, you know, all the things that you see on the screen. We're also often here for your caregivers as well. Sharsheret has programs for caregivers. I talk to caregivers, and we use the term caregiver very loosely. I think the term sounds like someone in the home, you know, emptying your drains and bringing you food and things like that, taking you to the bathroom. You know, that's not what we think of as a caregiver. That might be a caregiver, but, you know, anyone who cares about you is a caregiver in our mind. So that person might be in the home with you, they might be across town, or they might be across the country. You know, we're here for them, and certainly other social workers you come into contact will be as well. Integrative medicine is something that, you know, we're often discussing, whether it's nutrition or fitness or mental health. You know, this whole body approach is really, really important. You know, we know that when non-medical needs are met, the medical outcomes are better for people. So, you know, nutrition, there are so many theories out there. You have to be really careful. Only trust a registered dietitian. If somebody just calls themselves a nutritionist, that means they're probably not actually licensed like a registered dietitian would need to be. And Sharsheret actually has a program where we can match you with a nutrition coach or a nutrition coaching program. So you can definitely reach out to me if you have questions like that, but you could also ask your hospital social worker, because your insurance might cover a registered dietitian that's within your hospital system. Fitness can be something that seems so daunting to somebody going through cancer treatment, but actually even just getting up and walking 10 to 15 minutes a day is proven to reduce your cancer-related fatigue. So it is important, though I know sometimes it feels daunting, and if it feels too daunting, it just means maybe don't let people fill up your water all the time. You know, go walk over to fill up your own water. Things like that can actually help, you know, boost that. And then, of course, mental health, you know, whether it's mindfulness or counseling or, you know, whatever it means, you deserve the support and you need the support. It's not letting me navigate. Okay. So Sharsheret was actually founded as a peer support program. Now we have lots of other resources too, but, you know, it really highlights the importance of peer support, mentoring, support groups, because social isolation, which we have more than ever now during the pandemic, you know, is a big problem with cancer. It is so hard to feel like people really understand what you're going through, because they don't. And we know that this type of high levels of stress, you know, lead to lower quality of life and faster disease progression. But the thing that is most hopeful to me is this study that I'm quoting on the page showed that one of the factors that helped people is just seeking social support. So not even getting it. Once you decide to take care of yourself and seek people out to help, that helps. So Sharsheret can help in lots of ways. Please, you know, don't hesitate to reach out to me or through our website. We have all these different types of resources that we can mail to you, resources over the phone. We have a genetic counselor, resources for kids, family, everybody. So like they said, they'll send out my contact information, but that's that for me. Thanks.
Thank you so much, Amy. That was great. And as a fellow social worker, I like anything that highlights how wonderful social work is. I think it's also really important to emphasize to anybody on this call that as this is a multi-organizational, you know, effort tonight, we are all in this together, all of these organizations. And we are not proprietary, we are not territorial. We want to make sure that you know that all of the organizations represented here have wonderful services, and we would like you to take advantage of all of them. So even if you might be affiliated with Woman to Woman at Mount Sinai and you hear something at Chershred, or you hear something, at one of the other ones, please take advantage of that. Whatever is out there that might be helpful for you, we want to make sure you know. There are so many great organizations doing so much great stuff. And as Amy said, and as Dr. Outberger said, using the social worker as a liaison to access additional resources is always going to be a great first step. So thank you all. So our last speaker is really important to hear the patient survivor perspective. So Janice Stacy is an ovarian cancer 8-year survivor in Houston, Texas. She's thrilled to share her journey through diagnosis, treatment, and life after ovarian cancer, and hopes to give you a window into what you might expect. And Janice is happy to answer any questions and disclose any tips and advice that may be of help from her personal experience. She wishes you all an easy and successful journey and good health. And thank you so much, Janice, for being willing to be here with us today and share your story about your cancer diagnosis with our participants.
First of all, can you hear me?
Yes.
Okay, unfortunately, my camera is not working. My husband has tried to get it fixed and can't do it. And I spent 10 minutes putting on my stage makeup, and now it doesn't matter.
We will have to listen to your voice and be guided by your voice, but thank you anyway.
Okay. First of all, I'm very happy to be here. It's a real honor for me to share my story with you, and I hope it's helpful to everyone there. I'll start off by saying, when one of our friends turned 70, he told us everything changed. He started having major medical issues, and he said to us, "Don't turn 70, it's no fun." Well, 10 days after I turned 70, the fun started. I was diagnosed with ovarian cancer. Never in my wildest imagination did I ever think I would have cancer. I had been healthy my whole entire life. I have no children, so I had never been in the hospital. I had the flu once 50 years ago, and all of my yearly exams were exemplary. Doctors were always amazed at how healthy I was. I was a very active person who exercised daily and have always enjoyed exercising. I was diagnosed with ovarian cancer, high-grade carcinoma, likely favoring high-grade serous carcinoma, on March the 10th, 2015. I had to beg my primary doctor to order a CA 125 blood work for me. I was surprised when I was told I had cancer. My doctor said to me, "I will cut to the chase. You have ovarian cancer." For some reason, I had no reaction at all. I just stared at my husband with no emotion. I think I made up my mind at that time that I was going to fight it and be okay. I'm not sure if I had stage 3 or 4. I just looked in my records and I figured out that I have histolic grade. My histolic grade is high grade, and I don't know how that relates to 3 or 4. Anyway, about 4 weeks after being diagnosed, I had a complete hysterectomy. Soon after the surgery, I was treated with 6 rounds of carboplatin and Taxol. I was a very fortunate person. I never once got sick from chemo, but I did suffer from fatigue. The one complication I had from the chemo was neuropathy in my feet, and I still have it today. Because the cancer had spread to a small portion of my colon, my doctor advised me prior to going into surgery, I would have an ileostomy. Well, my positive attitude went south when that happened. I absolutely hated the circumstances of the ileostomy. I upset my oncologist once for complaining about it. She made me realize it saved my life. This is a good example of the importance of listening to your doctor and following his or her recommendations. As I mentioned, I had very few complications with chemo. On the other hand, my younger sister, who was 9 years younger than me, was also diagnosed with stage 4 clear cell carcinoma of the uterus and ovary the year prior to me. She did get very sick with nausea from the chemo. I think her main problem was she just did not take the nausea medicine as instructed. Instead of taking it as prescribed, she waited to take it when she would get sick. She would convince herself that the chemo was going to make her sick, and so she expected to be nauseated. We tried so hard to make her understand she was not doing it right. So, most importantly, listen to what your doctor said to you. It actually took me about 1 year to feel like I was totally recovered from the surgery, and I do think the pouch had an ill effect on me. I could not exercise because it had prolapsed and I was slightly depressed. I used to lay on my couch and watch people go by in front of my house, walking or bicycling, and I could not do it. That almost killed me. As soon as I felt better, I started my normal weekly exercise routine, doing a combination of walking 2 or 3 miles a day, aerobic exercises, sometimes walking stairs, and riding my bicycle. Of course, I did this on different days, not all of it the same day. I felt great, and my attitude was also great. I might just mention that I did have anxiety when all of my treatments were finished, and I was put on a 3-month schedule for seeing the doctor. I loved my doctor and her staff, so I felt sort of like I was being abandoned. I needed assurance that I was going to be okay. I also felt this way when I was put on a yearly schedule last year. I learned my anxiety was unwarranted because my doctors were always there for me. And they were on top of things when, in September of 2016, 1.5 years after the original diagnosis, the cancer recurred. I had absolutely no symptoms and felt wonderful. I went in for my normal checkup and my CA 125 had gone up several points. Even though it was below the range of 30, 35, I think, the doctor was concerned and ordered a CAT scan. The cancer was on my spleen, a small portion of my stomach, and they thought it may have been on my pancreas. Another surgery was performed, and it was so much easier than the first one. I think the main reason for this was because I had been exercising so diligently. I was put on 6 rounds of carboplatin and Doxil. I did ask my oncologist if there was a chemo that would not make my neuropathy worse, and she decided on the Doxil instead of the Taxol. I still have neuropathy, but I am taking cannabis oil without THC, which helps. And the reason I know it helps is that I've gone on trips before and forgotten to take the medicine with me, and I could feel the tingling in my feet. So I'm a firm believer that it has helped me. The only effect of the neuropathy that I have is that I have to wear a certain type of shoes, but other than that, my feet don't really bother me. Recovering from this surgery was a piece of cake. I was up and at it within a couple of weeks. I felt so much better than the first time. My friends and family accepted the second diagnosis with much trepidation. In March of 2023, it will be 8 years since my original diagnosis and 6 years and 4 months since my recurrence. I did participate in several trials, and it was easy for me to do so because I live in Houston, but it may not be as convenient for some of you. I have information on some of the trials that I participated in if anyone is interested. I think attitude and state of mind are huge assets in living with and surviving cancer. My sister always considered the worst. I didn't. I loved my sister very much, and I miss her all the time. We had 2 different characters. We were just different. Unfortunately, her endurance was not as good as mine, and she passed away in March of 2017. We did genetic testing, and we were told our cancers were 2 different types and not considered genetic. I have another sister, and she decided, along with her doctor, to have a complete hysterectomy, and she is fine today. How do I feel? I feel great. Cancer is not the worst thing in the world. My role model is my husband's first cousin, who was diagnosed with ovarian cancer in the year 2000. And 23 years later, she is still with us. Don't let cancer define you. I am in no pain. I can function mentally and physically just as I did before being diagnosed. I live a very active life and enjoy volunteering with Buffalo Bayou Partnership in downtown Houston and a charitable group called the Falk Foundation. Of course, I'm also a volunteer with Jimmy's Mission. I have made many friends with both of these groups. Again, thank you for letting me present my story, and I'm happy to answer any questions that anyone has. Thank you for letting me participate.
Thank you so much, Janice. We really appreciate hearing your story. And I think the best part about your story, to be honest, is hearing how active you are right now, despite everything that you've been through, that you're traveling and you're volunteering and you're leading such a full life. And I hope that what most women take away from that is, you know, whatever your experience is, whatever treatment is, whatever side effects you're going through, that this is possible. Again, this is your story and everyone's story is different. But the fact is, you know, that this is possible to go through, you know, lots of treatments and surgeries and everything like that, and still be able to lead a fulfilling, full, very, very active life. So that was wonderful.
And
So we have about 10 minutes or so left, and we are going to now turn to our Q&A. This is your chance to put questions in the chat. You can also do the old-fashioned, you know, wave your hand virtually or wave your hand like this, and we will get to you because I'm sure there are a lot of questions.
okay.
So you are welcome to kind of stick those in, and what I can do is I can kind of help moderate and figure out who those will go to. So I see a
Rachel, it
question.
looks like we have one in the chat already.
Terrific.
For
So-
Dr. Altwager. I believe it's, well, probably more so around COVID, if going through chemo, if going through chemo, other than getting COVID vaccine and boosters, what specific precautions should we take regarding masks or not masking? Under what conditions should we be wearing masks? And then any other specific precautions on immune compromised persons should be taking to avoid COVID?
That's a great
Sure,
question.
yeah.
Yeah.
Sorry, yeah. No, it's a great question. And I think that there is some, it can be confusing in terms of what to do with COVID, but I think that the best thing to do, and what I tell my patients, again, as you stated, getting vaccinated now, you know, timing wise, and you know, we just don't want to get the vaccination right at the time when your bone marrow will be at the lowest, or your white blood cell count will be at the lowest, not because it'll hurt you, but because your immune system won't make a good response and you won't be able to really effectively, you know, gain anything from that vaccine. So you want to make sure to do it when right before, if you're in the midst of chemotherapy, right before you get chemotherapy, maybe the day or two, or a couple days before the chemotherapy cycle. Now, of course, that depends on what your cycles are and everything, but just ask your physician; they'll know. In terms of the medications, if you come down with COVID, you know, Paxlovid is also a good agent for people. Now, in terms of what to do in a day-to-day life, if you're currently getting chemotherapy, I would recommend, particularly around when you nadir, and that's a term that if you don't know, you know, make sure to ask your physician. They'll be able to explain, you know, when that is for you. But that means the lowest point in your white blood cell count, when you're most susceptible to potentially gaining infections. Ask when your nadir is, and ask if you have to be going out during your nadir in public or in around people, be sure to wear your mask then. If if you're concerned. Now, I would highly recommend that. I would also recommend, even if you're not at your nadir, to wear masks if you're in a public place, if you're going through chemotherapy, because it may be that your nadir isn't predictable, and it may be that you may drop your white blood cell or drop your immune system even outside of your nadir. So certainly if you're on active chemotherapy, I would recommend using a mask in a grocery store, or if you're going to a gathering, wear a mask there. I would say I would be cautious be cautious to not engage socially. I think if you wear a mask and you want to go to a gathering, I think that's totally reasonable at this point in the pandemic. I think the best thing we have to help prevent the spread are really the masks. Now, again, if you're at your nadir, don't go to a party. I would recommend, but if you are outside of that time, then I think that's fine too. I think that answered the question about the masks.
Thank you so much. There's actually another question in here. It was a specific question that was directed actually towards Janice, but I'd like to make it a little bit more of a general question and ask each of the three participants. It has to do with trials, because I think that's something that's very important. And I'd love to get the perspective of each of them. So in terms of trials, could we just, from the perspective of the physician, the kind of psychosocial perspective, and the patient, if we could just talk about that. So maybe Amy, if we could start with you, and I know that, Sharsha does have some information about that. What would you
Yes.
suggest if a patient is curious about trials? How can you help kind of support investigating that from a psychosocial perspective?
Absolutely. So we do have some resources we can mail, or resources on our website about finding clinical trials. I also help support people who are looking for them or considering them. The first is to ask your doctor, but your doctor might not know of all of the trials that are out there. So it is a good idea, to do some exploring on your own. There is a government website that all trials have to be listed on, and you can see if there are any that you might be eligible for. I think the psychosocial perspective on trials is you are going to want to feel like you did everything possible. And if there's a moment when, something else might help, or maybe your treatment isn't working and you want to look for other options, it can be a wonderful resource. That said, they're not always available for every type of cancer, and they might not be anywhere near you. There are resources out there that can help you, find transportation and housing and things like that if they are somewhere else, which a social worker can help you access. But it's not, I think some people think there's always a clinical trial option, and I think it is important to know that they're not always an option.
Well, thank you so much. And Janice, from a patient perspective, we don't have a lot of time, so just briefly, if you don't mind, what made you decide to pursue? You mentioned you did a few clinical trials. What made you decide to go down that route? Janice, I'm not sure if we lost you here. So let's go to Dr. Outwerger. As the physician, if you do have someone, Janice, you're back.
Yeah. I didn't really do the trials for myself. I did it for other people, to help other people and to help the hospital. And because I loved my doctor so much, I was willing to do anything. But I mean, I did participate. It was no trouble at all because of the fact that I live in Houston. I'm only 10 miles from the hospital. So I was more than willing to participate in the trials. And one that I think might have helped me was one of the beta blockers trials that I did. And it was, I don't have it. Let me see right here. Anyway, it was taking beta blockers to help you live longer, and maybe it helped. Because I'm here 8 years later.
Well, you certainly are a success story. And I think it does show that trials are absolutely something to consider. And Dr. Outwerger, as a physician, if you have a patient that comes to you and says, I'm interested in trials, what would then happen next?
Yeah, that's a great question. Typically what happens, the patient will ask if there are any trials, and what I'll do, I'll go through and review their past history. Now, if I've known them for a while, That doesn't take very long, and in general, I can kind of just list off a couple of ideas of trials and so forth. But if they come as a second opinion, I generally like to go through all of their history, all of their chemotherapy, because sometimes prior chemotherapies can prevent you from being able to go on trials. And so, before I speak a whole lot on trials, I usually like to understand exactly which ones they'll fit into. And so we need to know about past chemotherapy. We need to know about the grade, and the grade could be, some trials are low grade or grade 1, or sometimes they're high grade, grade 3. And so it depends on what grade they are, depends on what stage everybody is, and so and also the type. Sometimes there are trials for cervical cancer, sometimes there aren't. Sometimes they're just the way the trials have been closed. Just if they have enough people that were involved in it, there aren't any trials that are currently open. So be sure to ask about trials. There's generally a lot out there, and if your physician doesn't know about any in their particular locale, be sure to say to them, hey, do you know any place where I can go to get a second opinion for a trial? And they'll be more than happy to say, oh yeah, MSK Memorial Sloan Kettering has these additional trials, or maybe Brigham and Women's has one. I'm talking about the ones in the Northeast because I'm from this area, but yeah, I mean, make sure to ask, and if they don't have any, ask if there's any around that they may know.
Thank you so much. So we are technically out of time. So what I'd love to do then is I'd like to just ask one specific question and get a short answer from each of the 3 panelists. And if it's okay, Ashley, if you can save the chat as and let's figure out, because I'd like to make sure everyone's questions do get answered, even if it's more on an individual basis, then I think that would be great, so we know who to direct them to, because these are all really important questions. So the question I'd like to ask each of you is, what is the one takeaway piece of advice you have for any person who is newer in their cancer journey, who is watching this right now, that you would like them to take away? So Janice, why don't we start with you?
Well, I think being positive is something that really helps. I mean, I'm very, very fortunate that I am a positive person, but I think you're born that way. I mean, my sister was very negative about a lot of things, and we were sisters. So I think it's just part of your being. And I think just looking at the bright side of things really helps. I mean, it's kind of hard to do when you have cancer and you don't feel well. And of course, in my opinion, exercising is so important.
The mind-body connection, I think, seems like you're talking about a lot. So thank you so much. And Dr. Outwerger, what would you say the biggest takeaway for someone newly diagnosed who's watching this?
Yeah, I really feel strongly about people advocating for themselves and really pushing their physician, not in a adversarial way, but in a questioning way. And I think, listening to Janice's story really highlighted that, the initial time that she pushed for the CA-125, the time that she pushed for the change in the type of chemotherapy because of neuropathy, and it might be that you don't even know that there could be a different type of agent, but as long as you advocate and say, hey, I've been having a lot of bad neuropathy, and the physician can easily, that's an easy fix, so just advocate for yourself, and don't, I think to a degree we have to listen to our physicians, no question, but I think it's also important to say, hey, I feel a little uncomfortable with this or that, and what do you think? And it makes a nice working kind of team.
Absolutely. Thank you so much. Again, the importance to really kind of partner with your medical team, and, feel free again, as you said originally, to ask questions. And Amy, what would be your one piece of advice?
I feel like you could probably guess this because I'm the social worker, but just connect with other people, whether it's the social worker at your hospital or share it. We're here for you, or your family and friends. A lot of people don't realize that you need support even after treatment ends. And people feel like, I had so much support and now that I'm doing a little bit better, but I have more anxiety, I still need the support and nobody's there for me. But really and truly, people they just don't know. People can't read your mind. So you have to connect with them and share what you need so that you can get it.
Thank you so much. Again, I don't want to discredit the fact that we see some really important, really good questions in the chat. We are going to do everything we can to get those questions answered for you. So please do not be discouraged if they're not being answered live right now in this forum. We see your questions. But in the interest of time, we are going to end.
May I say one thing? May I say one thing, please?
Sure.
If anybody has a question and they would like to email me, I'll be more than happy to answer their email questions.
Thank you so much, Janice. Are you able to put your email in the chat? I don't know if that's something that you.
Let me see, there's a chat. Okay, yeah, I can go to the chat and oh, I see the questions. So people are asking questions. Okay, I'll go to the chat and answer the questions.
Well, I think since we're going to be cutting this off soon, if you're comfortable, if you'd like to put your email in the chat, I see that Amy.
Oh,
did.
no, I don't mind. Yeah.
Okay, terrific. And then that way if people want to speak, directly. So thank you so much. And thank you, Dr. Oliver, for making yourself so available. Before we wrap up, we need to absolutely thank our incredible presenters. Such a wealth of information. As you can tell, we could probably go for hours and hours more because people have so many really important and valid questions to ask all of you. And we're so appreciative for you sharing your range of experiences and knowledge. I know that Ashley likes to end with a little bit of a plug for community organizations. So maybe you want to do that before we
Yes, of course. Well, of course, your hospitals have lots of resources. Your statewide might have an organization that would be able to help you as well. Wisconsin Ovarian Cancer Alliance, we help the state of Wisconsin and Northern Illinois. Lots of states have their own community-based organizations that would offer a whole nother set of resources from the hospital. So if you're able to double dip and get services from both, highly, highly, highly recommend.
That's great. And again, all of the organizations here are committed to the same goal, to making sure that you are not alone as you go through this journey, to connecting you to relevant resources, either within our organization or through all of the many other amazing organizations out there, and to just make sure that you are, as Dr. Altlager said, that you are your own self-advocate, give you the tools to advocate for yourself as you go through this journey. We want to thank you all again so much for joining us. You took an important step in being a self-advocate by being here tonight. We hope that people watching this live or people watching it recorded get so much out of this. And again, we want to say extra thank you to the presenters for making yourself available even beyond, when this Zoom goes off, sharing your information and being so generous with your knowledge. Huge shout out to the collaborating organizations who put this together and supplied our fantastic speakers. And it is a pleasure to meet other people working in the same space, as our goals are all common and united. So thank you, everybody. Stay safe, be well, and we are here for you however we can be. You will be getting a follow-up email with lots of helpful information and links. So please check your inboxes for that. Have a good night, everyone.
Thank you.